All right, let's dive into a topic that's not just high yield for your exams, but a true can't-miss medical emergency you'll see on the wards: toxic megacolon. Let's get straight to it.
Okay, so picture this scenario. This is the kind of classic question stem you're going to see again and again. You've got a young patient, they've got a known history of IBD, and right now they are acutely severely ill. This is the perfect setup for a diagnosis you absolutely have to make.
So what's flashing through your mind right now? The patient looks sick, that's the toxic part. Their abdomen is blown up, but when you listen, nothing. A silent abdomen. That's a huge red flag for paralysis. Your number one concern here, without a doubt, has to be toxic megacolon.
So to really understand this and lock it in, we've got to look under the hood. What is actually happening that causes the colon to suddenly and dangerously expand like this? Let's break down the pathophysiology.
Here it is, your textbook definition. But let's pull out the key words for your exam. First, non-obstructive. This is super important. It's not a tumor or a blockage. And second, systemic toxicity. It's that deadly combination of a massively dilated colon plus a patient who is systemically sick that really defines this whole condition.
Now what's so cool about this is how simple the core mechanism is. It's a vicious cycle. It all kicks off with severe inflammation, some kind of really bad colitis. This inflammation causes a massive release of nitric oxide, which, as you know, is a really potent smooth muscle relaxant. This effectively paralyzes the wall of the colon, and when that happens, you get this massive, life-threatening dilation. It's a simple and incredibly deadly cascade of events.
Okay, so what kicks off this whole process in the first place? Well, it's not just one thing. Let's walk through the primary triggers that you're most likely to get tested on.
The best way to think about this is to put the causes into two big buckets. Bucket number one, inflammatory bowel disease, with ulcerative colitis being the absolute classic cause. Bucket number two, infectious colitis. Now, if you remember one infection from this list, make it C. diff. If you get a question stem about a patient with recent antibiotic use who looks like this, C. diff has got to be at the very top of your differential. And this is a great slide because it shows how other things can push a vulnerable patient right over the edge. Anything that slows down the gut, like opiates or anticholinergics, are major culprits. And look at this list. Suddenly stopping steroids, getting a barium enema, or even just having low potassium can be the final straw. You've got to hunt for these precipitating factors in any clinical scenario.
Okay, let's focus in, because this is arguably the most important section for your exams. How do you officially make the diagnosis? There are specific criteria here, and you just have to memorize them. Let's start with the magic number. The absolute cornerstone of the radiographic diagnosis is a colonic diameter greater than 6 centimeters. It's usually the transverse colon. 6 centimeters. Burn that number into your brain. So when you're looking at that plain abdominal film, you're hunting for that dilation, again, over 6 centimeters. You'll also see this thing called loss of haustration, where the normal folds of the colon disappear, making it look like a big, smooth, featureless pipe. Seeing multiple air fluid levels is another classic sign that tells you the bowel is paralyzed and dysfunctional.
Now, let's put it all together with the formal Jalan criteria. This table makes it super clear. First, you must have the radiographic evidence we just talked about, that colon wider than 6 centimeters. That's non-negotiable. Then, you need at least 3 signs of systemic toxicity from that middle column. So things like a fever, a heart rate over 120, or a high white count. And finally, you need at least one of these major clinical signs at the bottom, like dehydration or hypotension. Just think of it like a formula. X-ray plus 3 toxicity signs plus 1 clinical sign. Done.
And of course, the labs are going to back you up. You'll see all the signs of inflammation and infection you'd expect: a high white count, an elevated CRP. Anemia is really common, usually from bleeding in the GI tract. And remember hypokalemia? It can be both a cause and a result of what's going on.
So, once you've made that diagnosis, the clock starts ticking fast. Management is a race against the single most feared complication: perforation. Let's get into the action plan.
First things first is always stabilization. This isn't a wait-and-see situation, it's an all-hands-on-deck, right-now situation. You're going to make the patient NPO, nothing by mouth, and you'll probably place an NG tube to decompress the gut. At the same time, you're hitting them with aggressive IV fluids, correcting electrolytes, and stopping any of those offending drugs we talked about. And everybody gets broad-spectrum IV antibiotics to cover for the huge risk of bacteria crossing that damaged gut wall.
Okay, next up, you have to treat the underlying cause. And this is a major fork in the road.
If it's an IBD flare causing all this, the answer is high-dose IV glucocorticoids. But, and this is a huge but, if you suspect or have proven C. diff, the treatment is totally different. You're going with antibiotics like oral vancomycin. Notice that it's oral. You need that drug to get directly inside the colon to do its job.
This slide right here is critical, absolutely high yield. When do you call the surgeons? Well, you call them immediately if there's an obvious perforation or if the patient is crashing on you hemodynamically. But here's the other key trigger: failure to improve. If you've been hammering them with aggressive medical therapy for 24 to 72 hours and they're not getting better, it's time for surgery. You cannot delay.
And when surgery is the answer, the standard procedure is a subtotal colectomy with an end ileostomy. What that means is they remove most of the diseased colon and then bring the end of the small intestine out to the abdominal wall to create a stoma. It's a huge operation, but it is absolutely life-saving.
So why all the urgency? Why the aggressive treatment, the quick trigger for surgery? It's because the stakes could not possibly be higher. Let's take a look at the consequences of failing to act.
The one thing we're trying to prevent, the most feared complication, is colonic perforation. The second that thin, stretched-out bowel wall gives way, stool spills into the abdomen. That causes a massive infection called peritonitis, which spirals very quickly into sepsis, shock, organ failure, and all too often death. And this chart really drives that point home. Just look at the difference here. Without perforation, the mortality rate is significant, but it's manageable. But the moment perforation occurs, the risk of death skyrockets, sometimes as high as 40%. This is why every single step we take is a race against that rupture.
So if you take only one thing away from this whole explainer, let it be this. Toxic megacolon is a full-blown medical emergency. Your job is to recognize the signs early, apply those diagnostic criteria like a checklist, and act fast and aggressively to prevent perforation.
And let's finish off with a final, more advanced question to really get you thinking. So, your IBD patient isn't getting better on IV steroids. Before you make that call to surgery, is there another medical play you can make? The answer is yes. This is where you start thinking about second-line rescue therapies, like infliximab or cyclosporine. Knowing these next steps, well, that's what separates a good score from a great one. Thanks so much for joining us.